Hello to everybody that is joining today's webinar and making the time to come and listen to the topic of cow's milk allergy. Today's topic is what is new in the diagnosis and management of cow's milk allergy. My name is Rosan Meyer. I'm a specialist pediatric dietitian and I straddle a couple of countries in that I have an academic position in the UK as well as in Belgium, and I have a clinical practice in the UK as well. Today's topic is really close to my heart, and I'm hoping that after today, you'll really have a good idea of all of the new research and also how it impacts on your practice. I'd like to start off with sharing my conflicts of interest, which primarily covers presentations like this and also some research grants as well. Now, if I look at the last 5 years in terms of publication and you look on PubMed, look using different search terms, whether that's cow's milk allergy in children, cow's milk allergy intolerance or growth, you'll see an exponential increase in publication. That's not only primary research, but also guidelines, telling you that practice has really evolved over the last 10 years in particular, which is not only exciting, but also hopefully positive for the children that we are diagnosing and managing. So I want to start by providing you with a little bit of background. And I think it's important to start with the prevalence of cow's milk allergy, because the most well-known study is the EuroPreval study, which was done in Europe. And it's a study that's based on double-blind challenges. So these are children that have their diagnosis confirmed and recruited 12,000 infants, which showed an overall prevalence of just short of 0.6%. Of cow's milk allergy, but with a big range. I want you to focus on the screen and look at your screen. So in blue is the total population of cow's milk allergy. In gray is the population of IgE-mediated allergy, which implies the rest of the population of the space would be non-IgE-mediated allergy. Now, what you will already see is that, for example, in the United Kingdom, you'll have almost half of the children having a diagnosis of non-IgE-mediated allergy. But when you look at Lithuania, Spain, and for example, Germany, you'll see that in fact, based on the EuroPreval study, none of the children have got a non-IgE-mediated cow's milk allergy, and all of them have an IgE-mediated allergy. That, of course, created a lot of concern, because it is not true that non-IgE-mediated allergies only exist, for example, in the UK, Netherlands. But it highlights the problem still that we have with the recognition and the diagnosis of non-IgE-mediated allergies. You will look on the right-hand side of your screen and find a lot of different prevalence studies, primarily based on IgE-mediated allergies, giving you a range between 1.9% to even as high as 7.5%. The overall estimate at the moment, depending on which country you come from, is between 0.5 to 3% at 1 year of age, which means the vast majority of healthcare professionals that deal with pediatrics will see children with either an immediate type, an IgE-mediated allergy, or a non-IgE-mediated allergy. So what am I going to cover today? Because you've logged in today to hear what is new. I'm going to talk about prevention, and then I'll move into the management, and then the active introduction or oral tolerance induction. Let's start with prevention. I think all of you have seen the different guidelines, and depending on where you're logging in, you will know your guidelines. When breast milk is not available, when we're looking at allergy prevention, most of the guidelines say the same, that when breast milk is not available, a standard infant formula is recognized, and there has been a move away from either partially hydrolyzed or extensively hydrolyzed formulas when we come to suggesting formulas. There is, however, a note that the European Academy for Allergy and Clinical Immunology have added to their guidelines, which has caused a lot of discussion. The European guidelines indicate that the avoidance of regular cow's milk formula as supplementary feed for breastfed infants in the first week of life. Now, that guidance was generated by a number of studies, but I'm going to show you the two studies that have a good and robust methodology to show you what the debate that has been created around this recommendation. The first study is by a Japanese group, and it recruited 330 patients, in fact, already prior to birth. So these were mothers that were enrolled prior to birth, and they were randomized then at birth to yield around 150 infants per group. The randomization were as follows. The first group were breastfed plus cow's milk formula, and they received 5 milliliters of cow's milk formula from birth, so within the first 24 hours. The other group was breastfed, and if they received any formula, it would be an elemental formula, so an amino acid formula. And these were then assessed for a primary outcome as cow's milk sensitization, so just that is IgE positive, and secondary outcomes for challenge-proven food allergy. And they also looked at egg allergy. So the first interesting finding was that cow's milk sensitization in the group that received the elemental formula on top of the breast milk was significantly lower than the group that received breastfeed plus the 5 milliliters of formula. The second interesting finding was that when you look at total oral food challenge proven food allergy per se, so that is not just cow's milk allergy, the group that had the cow's milk infant formula plus breastfeeding had significantly more challenge proven overall allergy and also significantly more egg allergy. So the overall finding from this study is that a lot of the food allergies, not only cow's milk allergy, can be prevented if no cow's milk formula was given within the first 3 days of life. Now let's look at another study. Again, a study from Japan. In this study, they randomized patients within the first 5 days to make sure that within the first month, they had two groups, both were breastfed. One group received breast milk with 10 mils or more of infant formula, so cow's milk based formula, and the other one soya formula. You can already see, if you look at my right side, when they looked at the proportion of cow's milk allergy, challenge proven cow's milk allergy, there was a significant difference with the group that was avoiding cow's milk having 6.8% of challenge proven cow's milk versus 0.8% in the group that received 10 mils or more. You will see when you look at the data that overall the risk difference was significantly higher if you did not get the cow's milk formula early versus those that had no cow's milk formula. Now, it leaves many of us confused, but I think there are some differences here. The first study that I showed, they started much earlier, and the volume was much lower, so 5 milliliters. The other study, the randomization occurred at day 5, but they received between 1 month and 2 months, 10 mils or more, and many of them had much more. However, the problem that we've got, it leaves us here that in terms of clinical guidance, if you said to me, what should we do? More research is needed to provide clear guidance whether the early introduction, when I say early, within the first week of life, in fact has a protective or a negative impact in terms of increasing cow's milk allergy. What it does, though, reinforce is the importance of supporting breastfeeding and having a discussion with the parents beforehand to find out what their requirements are. Do they want to breastfeed? What if breast milk is not available? So that is really, at the moment, if you said to me what is different in terms of guidance, that is what's creating debate. If we move on to now management of cow's milk allergy, what has changed there? There have been a lot of guidelines published that have been based on systematic reviews, really condensing all of the new publications. And I think the guidelines that are very useful and representative of healthcare professionals from all over the world would be the DRACMA series. I have here just mentioned the DRACMA series that have got a specific role when we're looking at elimination diets, tolerance induction, and the management. And some of these I have also been involved. And what I'm going to do is try to take you through a journey in regards to the highlights of some of these that may change your practice or that really needs reinforcing. So this one was one of the DRACMA series 7, and it looks at milk elimination and reintroduction as part of the diagnostic process. And here we think in particular around non-IgE mediated allergy, where there is not a specific diagnostic test, where many children will have to go through an elimination process and a reintroduction process to confirm the allergy. What is really critical here, and although it's known, is the reinforcement of an oral food challenge or a home reintroduction in regards to confirmation of a cow's milk allergy. The concern has been highlighted several times that in many cases children are just placed on an elimination diet without the confirmation, in particular for non-IgE mediated allergy, which leads to overdiagnosis. This publication provides you with very clear guidance on not only the length of time for elimination, but also the reintroduction process, and also provides guidance on oral food challenges, which of course will need to be supervised if it's an IgE mediated food allergy. So why has there been such concern in particular around non-IgE mediated allergy and the overdiagnosis? It is because of many of the symptoms overlapping with what was previously called functional gastrointestinal disorder and now called disorders of gut-brain interaction. This is a lovely paper from Daniel Mundblit, and they've taken the patients from the EAT study. So this was a patient group that was exclusively breastfed and recorded their typical symptoms that would overlap often with non-IgE mediated allergy, vomiting, that is, for example, reflux, colic type symptoms, and eczema. And you'll see how many are reported on at least one assessment, how many of them are reported on multiple assessments, and then in the small dot, how many of them had challenge-proven cow's milk allergy. So you'll see that 13% reported symptoms of cow's milk allergy that ranged between vomiting, colic, or eczema. And when they were challenged in a supervised way, only 0.7% of them had proven cow's milk allergy. If we're thinking about worldwide data, and this is lovely data from Ivan van den Plas, you will find that globally in infants, 21% have colic, almost 30% have regurgitation, almost 20% have constipation, and you will find functional diarrhea in almost 10% of patients. That is why it is so critical for us, in particular when we're thinking about non-IgE mediated allergy, that there has to be a reintroduction process. If we move on from there, we have not only our publication from the IACI side on the diagnosis and management of non-IgE-mediated gastrointestinal allergies in breastfed infants. But within the DRACMA series, that's DRACMA Series 10, there are some very good guidelines in terms of the management of cow's milk allergy in children that are breastfeeding. Now, why is this so important? The data that I've just shown you before is also applicable for a breastfed infant. So breastfed infants will also have colicky type symptoms, or they will have symptoms of diarrhea or constipation. And the concern that one has, which both of these guidelines highlight, is that we eliminate foods from the maternal diet, and as a result of that, the mother stops breastfeeding, and we lose the importance of breastfeeding because the elimination diet was too difficult. Now, there is guidance and concern also around the level of beta-lactoglobulin. This is a different publication by Daniel Munblit and Robert Boyer, where what they have looked at is using an eliciting dose of 0.1, so 1%, of children reacting based on IgE-mediated cow's milk allergy. So, and then they calculated based on that the beta-lactoglobulin levels that can cause a reaction through breast milk. And you'll see that in theory here, that it's a very small risk based on this theoretical calculation of reacting to the beta-lactoglobulin in breast milk. And you need to have at least 600 milliliters to elicit a reaction in a very small percentage. So only in 3 of 174 women, the beta-lactoglobulin levels were sufficient to create a reaction. Now, there are a couple of problems with this assessment. The first one, it does not consider non-IgE-mediated allergy. We do not have the eliciting dose for non-IgE-mediated allergy. And the reality is that we have significantly more reported reactions to cow's milk through breastfed children and non-IgE-mediated allergy. A classical example for that is food protein-induced proctocolitis. The second concern here with this theoretical calculation is that it does not consider the fact that beta-lactoglobulin levels are similar in extensively hydrolyzed formulas, and around 10% of children will react to extensively hydrolyzed formulas with cow's milk allergy. And the third factor that this theoretical analysis does not take into account is that the analysis does not consider the method of analysis and also atopy status. There are some studies to show that breast milk is different in children that in mothers that are atopic and their offsprings. Nevertheless, we need to be absolutely vigilant to not put mothers on elimination diets unless necessary. And this comes from the DRACMA guidelines that only if required, if the symptoms are severe enough and if there's an association that you do suspect that it may be cow's milk allergy, would you do a therapeutic elimination diet of 2 to 4 weeks. What is absolutely critical is that there needs to be a clear plan for reintroduction. What we do not want is that an elimination occurs without the reintroduction to confirm a diagnosis or to refute the diagnosis. So that is moving now towards the new guidance or the reinforced guidance on the elimination diet in cow's milk. So please do not eliminate foods, in particular cow's milk, from the maternal diet unless there's very clear evidence that cow's milk or any other allergen is a culprit food. So if we move on now to in the case where cow's milk is insufficient or it's not available at all, and you do think that the child has a cow's milk allergy, or your tests are conclusive in terms of IgE or specific IgEs, then you'll need to make a plan in terms of the alternative formula. For that, also within the last year, we had both the ESPGHAN guidelines as well as the DRACMA guidelines. And again, just to reinforce, these were extremely robust in terms of the methodology and have used a systematic review in terms of finding the data that were included. So if we look at both of these, and the reason I'm just including both of these is that most of the other guidelines are at least 5 or 10 years old. So that's why these guidelines are much more up to date. So if we look at the ESPGHAN guidelines versus the DRACMA guidelines, you see some overlap, but the first and most important aspect is that the extensively hydrolyzed formula remains the first choice of formula for the vast majority of conditions outside of anaphylaxis, for example, or eosinophilic esophagitis, which DRACMA also makes clear. What is different and adopted with both of these guidelines is that we now also have hydrolyzed rice formulas as a possible alternative to extensively hydrolyzed formulas in countries where this is available. Then we have also amino acid and soya formula, and I'll talk a little bit more about that. But if you need to take the most important message from this, is that extensively hydrolyzed formulas remains the first line for cow's milk allergy, and hydrolyzed rice formulas can be used when they are available also as first line. Now let's think about the smaller detail, because you saw there that DRACMA guidelines talks about soya as a third option there. So DRACMA guidelines talk about, and similar to the ESPGHAN guidelines, about the concern of phytoestrogens, but highlight that the evidence indicates that phytoestrogen is not really of a concern anymore. And there might be some preferences depending on the country, which includes also the cost of formulas. So when we're looking at the DRACMA guidelines, there's no mention of a below and above 6 months anymore with soya formula. In regards to ESPGHAN, they highlight not only the phytoestrogen, they talk about phytates and aluminium, but that the global evaluation has really showed that the modern formulas, soya formulas, actually are not harmful. And again, they do not make a mention of below and above 6 months. What they do mention is the co-allergy or concomitant allergy between children that have got cow's milk allergy and may also have soya allergy, which is significantly lower in IgE-mediated allergy and higher in non-IgE-mediated allergy. So in many of the non-IgE-mediated conditions, it's much more common. So ESPGHAN would recommend that if it's a non-IgE-mediated condition, you'd still be preferring, where available, an extensively hydrolyzed formula or an amino acid formula. The Galen task force are the only guidelines at the moment that still distinguishes between below 6 months and above 6 months and recommend against using soya below 6 months. So let's think about also this difference between growth and extensively hydrolyzed and amino acid formula. And I know that I've got a lot of information on the slide, but what I want you to take from this is that from the DRACMA guidelines, the systematic review included very detailed analysis on growth parameters. And similar to previous studies, they found that amino acid formulas, if a child has got growth faltering or it's got malnutrition, would provide superior growth in regards to catch-up growth. There is low certainty in terms of evidence of extensively hydrolyzed formulas compared to soya formulas. And so it's really the primary difference here is that the use of an amino acid formula in the more severe cases, in particular where undernutrition is present. What is important to note is that with ESPGHAN, outside of them having very similar guidelines in terms of amino acid formulas, they also talk about the presence of lactose in formulas. Whilst there's an acknowledgement that lactose intolerance is rare in cow's milk allergy, they do acknowledge that if there's severe malnutrition, for example, if there's enteropathy, that there's a flattening of the villi and there might be brush border damage. And in those patients, it may be worth considering a non-containing lactose formula according to Aspergan. So if we move on, you've heard me already mentioning the concern around growth. And the concern in particular that has been highlighted also with the guidelines from DRACMA is around height growth. This is not a new concern, but a very old concern, and was generated for the first time by Erika Isolauri, based on 100 children with challenge-confirmed cow's milk allergy. Now, if you look at this slide, you will see you have your control group in blue. You have the early onset of cow's milk allergy, where their length standard deviation score drops really quickly. And then you have the later onset of cow's milk allergy, where the length standard deviation drops, but not as dramatically as with the early onset. The concern that was highlighted with this study, and you can see that in spite of optimal management, according to the management plan in 1998, you cannot see catch-up length growth here. And at that stage, Erika Isolauri had already mentioned that a plausible explanation was that maybe there was a low-grade ongoing inflammation due to children not being on an optimal elimination diet, or that the feed, whilst there was no visible symptoms, that the feed still was not sufficiently managing the symptoms. So this was in 1998, but we have several studies that have since then shown poor growth in children with cow's milk allergy. I'm going to go to the most recent one, which I find quite exciting, because you often have got just snapshots of growth. But this is in fact a longitudinal study on growth trajectories in children with cow's milk allergy. Time zero is when a child was suspected with a cow's milk allergy. Then they went on to a 4-week elimination diet, and they had at that stage 100 children, and you'll see there's some drop off until time point 3, which is where they've been following them up after 3 months, where they've had 74 children that they had longitudinal growth measurements. What is also interesting from this study is that they also assessed the micronutrients and macronutrient intake. So if you look at the data from this, so this is the control on the left-hand side. You can see that, and you'll see that blue is weight for age, orange is height for age, and green is weight for height Z-score. You can immediately see a difference. I've highlighted the cow's milk allergic group versus your control group. That's time point 0 versus time point 3. And you can see that in time point 0 versus time point 3, at both time points, the children with a cow's milk allergy were significantly smaller and shorter than the children that had that were on an unrestricted diet. They also looked at correlation and statistic modeling and found that for weight for age, there was a positive moderate correlation with some of the B vitamins, magnesium, and iron. For weight for height, there was a positive moderate correlation with energy, protein, and some of the vitamins. And also you'll see iron here as well. The message here really is that there needs to be sustained monitoring. What was clear from this study was that they did not necessarily have a dietitian involved. And we have shown with some of our studies that having dietetic involvement can make a real positive difference in terms of growth. So let's move to then the next DRACMA guidelines, which goes really around the nutritional management. In this one, I was involved, but Karina Fenta was really leading this group. And we touched on a variety of different domains for nutritional management. And you can go back, it touches on the elimination diet itself, lifestyle changes, travel, and all of those factors. Again, my brief for today was really to think about what are the new factors and what can create controversy and really which may change your practice. And one of the factors that we often now get asked about is the plant-based beverages in older children. Now, plant-based beverages, we say that after the age of 1, if a child does not have poor growth, is not on a multiple elimination diet, and does not have feeding difficulties, ideally with dietetic guidance, you can actually switch them over. But to a fortified, so calcium, definitely, ideally some vitamin D, and ideally with higher protein, and ideally with some iodine as well. The problem that many have highlighted with the plant-based beverages is that they are classified as an ultra-processed food. And this is where a recent publication has come in to discuss what is the concern around ultra-processed foods. And there are different ingredients within ultra-processed foods that create concern. So ultra-processed foods are foods that contain ingredients that would not be available in normal food ingredients. What I mean by that, for example, it would contain an emulsifier. An apple would not contain an emulsifier. Or if you do a home-cooked meal, you would not be adding an emulsifier to it. It will add, for example, a flavor enhancer, colorants. And the concern here are the advanced glycation end products, which is a family of compounds that are products from non-enzymatic reactions between reducing sugars and proteins and lipids, and they occur at high temperature, so typical the Maillard reaction. And most of your ultra-processed foods, in particular junk food, so when it comes to your very high sugared burgers, or so your donuts or your sweets, things like that, or highly fried foods would be high in advanced glycation end products. Then you've got on the other side the emulsifiers, and those are there to stabilize emulsions. So many of our plant-based milks have got these in them because they have additions in them that need stabilization, because otherwise they would separate out. Now, there are some immunological changes that occur. Emulsifiers, for example, in particular, if we think about the gums, guar gum and pectin that are in plant-based milks, they can have an impact on the microbiome. Now, whilst we have highlighted this concern, there's always this dietary balance that needs to be managed. Then, of course, you need to eliminate all of the allergens and meet the nutrient requirements. But it is now our task also to be advising parents to say, ideally, as far as possible, have home-cooked foods and reduce the ultra-processed foods. That includes the pouches of baby foods that are high in refined carbohydrates, for example. Within reason, also, we need to consider the plant-based milks and saying, what is the benefit versus the risk? If the benefit is we cannot get the calcium in any other way, there are plenty of studies that show bone mineralization still is an issue. So it's really important to think about a balanced view so that the overall diet in terms of ultra-processed foods are addressed also when we think about cow's milk allergy. We're now migrating more to the end of this presentation. So we've talked about prevention, we've talked about new management principles and where controversy may be, and we're now thinking about active introduction or oral tolerance induction. Here we have got the DRAGMA guideline as from the series 14, who have looked at the cow's milk allergy immunotherapy. It is, again, a very thorough document, and I'm just going to give you the outcome from the questions that have been posed based on the research that was looked at. From the research that was looked at, it was suggested to use oral immunotherapy of unheated cow's milk. So one would not be using baked milk or cheese for oral immunotherapy, but pasteurized milk. For those people with IgE-mediated cow's milk allergy who place a high value on being able to consume milk. Conversely, they advise against oral immunotherapy for those patients where there is not a high value in the tolerance of cow's milk. What it's implying is that if there is, for example, a child where the inclusion of cow's milk is, in particular, if there's a nutritional need, would make a big difference. In those where there's a high value, then it's worth doing oral immunotherapy. But those where, for example, there's no value, and the parents, for example, said it's not important for them to have cow's milk in their diet, then they advise against it. If we move into, though, a different approach, which is an approach that was published for the first time in 2022 and led by Jonathan Horahane's group in Ireland. What that group did, they randomized children with cow's milk allergy, IgE-mediated cow's milk allergy, to the standard elimination diet. So what would normally happen, they would just be eliminating and then at a certain point would come back for their challenges, versus those children that would have an active introduction process at home following a low dose challenge. So these children would have at an eliciting dose of 0.5, so where 5% of children react, that is 0.1 ml of fresh milk. And if they passed that challenge dose, they would be progressed at home using the MAP ladder. Now, they used the old MAP ladder, which had 12 steps. I have since used the 6-step IMAP ladder with equal success. And what is exciting for this, when they looked at a tolerance based on challenges, you'll see that those in red, so those in red were the ones that had the early challenge dose and were progressed at home. We're on step 6, so that is the lasagna, where that is baked cheese, and we're tolerating it there already, and almost 90% at 12 months. And step 12, that means fully tolerant at 6 months. Imagine 30% were already fully tolerant versus 10%, and at 12 months, 64% were fully tolerant versus 37%. It's almost double. So that has really changed for many people, the practice. But I want to reinforce, if it's done, the ideal would be that they have this early challenge, low dose challenge dose, to establish those children that would react at very low dosages in the severe form, and those would not be progressed at home. We have also looked at, within our last RACMA guidelines, on the use of milk ladders and cow's milk allergy, because milk ladders have been used for a lot of different settings without necessarily always having the evidence. Just to kind of make sure that everybody's aware, milk ladders were initially developed within the UK to address those children with non-IgE-mediated allergy that they can progress with introduction at home. Based on the new data, we have provided a table which I think may be quite useful in terms of when milk ladders can be used or can consider to be used versus not. And we always say that a milk ladder should not be used in children that are older than 5 years of age, particularly if they've got a prior history of anaphylaxis, because older than 5 years of age are often those children that have more persistent cow's milk allergy. In fact, the ladder that I've just shown you, approach that was published in Ireland, all of the children were below the age of 1 when the immune plasticity is the highest. In non-IgE-mediated allergy, we advise against using the milk ladder in severe FPIs, in particular if they were reactive to low doses and were hemodynamically unstable. And we also suggest against using the milk ladder if asthma is poorly controlled. It's at the end a milk ladder where it's clearly been used as non-IgE mediated allergy, but not an IgE mediated allergy. This publication with Drachma provides you with some guidance to consider whether it's safe to be used at home, yes or no. So we're starting to come to the end of today's presentation, and I'm hoping you are all submitting also your questions whilst I'm presenting. So my conclusion really is the prevention of allergy, and including cow's milk allergy, their guidelines have been published, but you can see that the IACI guidelines were published in 2021, and already there's new data which implies that guidelines may need to be reviewed, in particular around the first week of whether the exposure of cow's milk within the first week is a preventative or actually harmful. That is something that we do need to discuss further and look at further publication. There are also new guidelines to the diagnosis and management of cow's milk allergy. Within this presentation, I have provided you with a lot of the Drachma guidelines, but I've focused those that are particular on the management of cow's milk allergy and where an elimination diet is used. Remember that breastfeeding is always the best and should be supported by us as healthcare professionals. And there are guidelines to guide you through the elimination and the reintroduction. When breast milk is insufficient or not available, there's also good guidance on when to use an extensively hydrolyzed formula, which is a mainstay for the management of cow's milk allergy. But hydrolyzed formulas are now added in areas where they are available and can be used as first line. For the first time, we have changes around guidance on soya, where although it's still not recommended as a first line in countries where EHFs and hydrolyzed rice formulas are available, the below 6 months and above 6 months guidance has been removed. There has been concern highlighted around the ultra-processed foods, in particular looking also at plant-based milks, which is something we covered in our Drachma guideline around the dietary management. There's more guidance on oral immunotherapy in regards to cow's milk allergy and the active introduction of cow's milk, in particular when we think about milk ladders and also thinking about IgE-mediated cow's milk allergy. I want to also reinforce at this point that it's critical for us to be safe. The message for today is certainly not that everybody should, with an IgE-mediated allergy, should go on a home introduction using a milk ladder. There are very specific safety guidelines that have been published, which I touched on today. And lastly, but most importantly, it is really important for us to think about growth and nutritional adequacy. And what the latest study in terms of growth has shown is that children need to be continuously monitored. It should not just be that they have their diagnosis and an elimination diet and then they're seen in a year's time. They should be continuously monitored from a nutritional perspective. And of course, ideally should be seen by a dietitian who specializes in food allergy. I'm thanking you for your attention, and I'm looking forward to having your questions now, which I'll be looking at as well, and hope to try to answer them as best as possible. Right, I can see a lot of questions that have been coming through, and many of them will come through. Just to reinforce, I already see that some people said they've missed some of the recordings. Please do not be worried. In a couple of days, you will get a link. All of those that have registered for this webinar will get a link that will be sent to you with the recording, so you can digest and look through all of the slides again and contemplate. And that will mean you will also have access to all of the references again. So let's have a look. I love this question. How often would you recommend length monitoring in infants suspected to have or proven to have cow's milk allergy? So I'm going to start off with that all children should have length monitored. And in fact, there's a lovely publication based on age, because of course, depending on the age, your velocity of length growth changes. So the velocity is much higher in a child below the age of 2 than a child above the age of 2. So I would normally say, in the ideal case scenario, if you have the resources, if you can do a length measurement every 3 months in a child with cow's milk allergy, that would be ideal. The reason I don't often do it more than every 3 months is that often because of the accuracy of measurements, you need to really press down the knees, and it often means that the changes can be really small. So I would say at least every 3 months would be important. If I have, though, a child that has got in particular length growth faltering, what I would do is I would implement a regime, and I would ask the parents to do both weight and length within 4 to 6 weeks time, just to see if they start pushing upwards. Because in many of them, if catch-up starts occurring, you can calculate your catch-up velocity, and that should occur quite fast. Right, so let's go through other questions. There's a question I'd like to ask about the practical application of the suggestions made from research. For example, around the ultra-processed foods. Working as a pediatric dietitian, we often work with families who may struggle with basic meal planning, for example. Great question there. As I said in my presentation, it is a balance. So what I first of all do is look at the overall dietary intake. So if we're talking about meal planning, so as far as possible, if we can have more home cooked foods rather than the ready prepared pouches, in particular the pouches that have got a higher sugar content, that would be my normal first line approach in terms of thinking about ultra processed foods. Then the second approach in terms of thinking around ultra processed foods, and if a child has plant-based milks, I look at the ingredients of plant-based milks and weigh that up in regards to nutritional adequacy. As a pediatric dietitian, I know I've got plant-based milks that will have some sugar in it, but have a higher calorie content, will have more vitamins and minerals, and I weigh that up against the nutritional status. Versus if I've got a child that is growing really well and has only one allergen that they have to avoid and is eating really well, I might then go and say, okay, I will look at a plant-based milk that's fortified but may not contain, for example, some of the gums and the pectin. So I have a very practical approach when it comes to that. So I hope that gives you a bit more practical approach. Here is another question on, can you comment on the role and use of comas? And is it mentioned in these guidelines? There's some of the guidelines, yes, where we do talk about comas. So first of all, comas score is not a diagnostic approach. It's an awareness tool. So for anybody that has not got knows the coma score, it's a awareness tool that has been developed by a group of scientists, including me. I'm part of that group. And has been validated. There are now well over, I think the last time I looked, I think 33, 34 studies and validation to it, where you have cutoff score in terms of highlighting whether a child may have a cow's milk allergy or not. So I think it plays a role in terms of the diagnosis in regards to highlighting the possibility, but it does not take away the elimination and reintroduction, which is really important to consider. So I'm continuing to go through the questions. I'd like to clarify about the rare cases of cow's milk allergy in breastfed. I understand cow's milk allergy affects overall 2 to 3% in the UK. Therefore, 1.7 is over half. So the 1.7 comes only in regards to the population of the mothers that would theoretically have sufficient beta-lactoglobulin to elicit a reaction. That is not 1.7 is not based on the percentage of prevalence. That's very important. So apologies if that doesn't come across. So it's 1.7 was from that study, only 3 of the mothers where they actually assessed the beta-lactoglobulin would have sufficient beta-lactoglobulin to elicit a reaction. That does not mean they have a reaction. So that's really important. It is still very controversial in terms of the actual percentage of how many of them present with symptoms. Host and Hauken did a study and this is already end of the 80s, where they mentioned that half of their group presented whilst being breastfed. They were not challenged during that period, but presented. So that's a different scenario. There are a couple of cases where they try to provide some estimates, but I think we're really struggling to get the prevalence for breastfed children that present with cow's milk allergy. There's a question here if milk ladder is not recommended above the age of 5. So that's a great question. So the reason for that is, since just to be clear, above the age of 5, the table that I've shown you is for IgE-mediated allergy. Above the age of 5, that it would normally be oral immunotherapy that would be used rather than a milk ladder at home, because the immune plasticity is quite low at that stage. And the other aspect also is those that with persistent cow's milk allergy are often those that more severe allergy. So it would be more oral immunotherapy. Here is a very good question. If a child presents with a reaction on the milk ladder, how long do you recommend to wait until re-challenging? So I think here the question is, what is the age of the child? Because if a child is very young, what I often do is I say, okay, stay. So if they, for example, have reacted on the cheese stage, but were absolutely fine on a pancake stage, I would say, okay, go back to the pancake for 2 weeks, try the cheese stage again if they're really young. If you've got a child that's, say, 2 or 3 years of age, I often would say stay on the stage for a month and then retry. So what is important is to remain on the stage if a stage is tolerated, and then retry. If they tolerated none of the stages, wait for a month and then start the milk ladder. But it's important for tolerance induction to remain on a stage that is tolerated. So let's see, we've got a couple more questions. There's a lovely question on concomitant soya allergy with non-IgE mediated cow's milk allergy. Is there any change in recommendation for introducing soya at weaning? So there is no specific guidance on soya at weaning, but pragmatically for non-IgE mediated allergy, what most people normally do is try soya at some point during complementary feeding. The highest level of concomitant soya allergy and non-IgE mediated allergy, and we've produced some of the data, and within the UK is around about 50%. So that means you still have a 50% of tolerance. So I would normally suggest start commencing complementary foods and bringing in the nuts and the eggs and all of those type of things. And then I would normally do soya as appropriate from around 8-9 months and still see whether the child is allergic or not, because you might still have a 50% chance of a child being soya tolerant, which can then be a really good alternatives in terms of products that are available. Then we have here a question, a longer question, so bear with me that I have a look at the question. So given the potential for infants with eczema to be more at risk of developing IgE-mediated cow's milk allergy from complete, is there any way to strike a balance of some inclusion of cow's milk with those that start with non-IgE-mediated cow's milk health prevent it possibly progressing to mixed cow's milk allergy? I'm just digesting. Is there any way to strike a balance of some inclusion of cow's milk with those that start with non-I? So I think what here is the question is around developing switching from IgE to non-IgE mediated allergy. So first, the switch from non-IgE to IgE mediated allergy is quite low. The last data, it's only around 5%. As far as I know, there's no specific studies that have shown that keeping some in will prevent that switch. But overall, if, for example, a child with non-IgE mediated allergy can tolerate, for example, a little bit of cow's milk in their diet, it's always good to maintain the small amount in if it is tolerated. The question of what your level of tolerance is, that's an important one. It's a question of, does it constantly flare up the eczema and it leads to therefore constant use of steroids? Then one has to weigh up and saying, actually, is it really worth it if you have uncontrolled eczema versus if the child constantly has diarrhea as a result of constantly being exposed? So I think there is this balance, but there's certainly, we lean now towards, if I have a child that comes to me where they have been able to tolerate some baked milk in their diet, and it's only on cheese and yogurt that they start reacting, and they're growing well, then I would say keep that baked milk in their diet, because certainly it will help with the tolerance induction. So here is a great question. For breastfed babies who have non-IgE mediated cow's milk allergy, do you recommend an extensively hydrolyzed formula or an amino acid formula as a backup formula if required? This is a great question. And I think it's 3 minutes before I'm having to finish. I'm going to just give you a little bit of background. So if we go on the background to say that extensively hydrolyzed formulas contain beta-galactoglobulin that is on par with the beta-lactoglobulin that some women, I'm using the word some women, are secreted within breast milk. And here, when you look at the studies of what is secreted through breast milk in terms of beta-lactoglobulin, there's huge variation. You have secretors and you've got non-secretors. So you actually have also mothers where there's no detectable beta-lactoglobulin, even if they consume cow's milk, where others, there are higher level of beta-lactoglobulin. So based on that, old guidelines have said that in children with, for example, food protein-induced proctocolitis, if breast milk is not available, based on the fact that they can react, the beta-lactoglobulin in breast is similar, it should be an amino acid formula. In our review in 2017, where we looked at amino acid formulas in 2017, we already looked at the evidence of the studies and could not find convincing evidence for useful amino acid feeds in children that are breastfed. So I would say to you, and that's the same that we said already in 2017 from our publication, that it really depends on your child. If you've got a breastfed child that has an enteropathy that is in fact not growing, then your choice is very obvious, an amino acid feed. But if you've got a child that is thriving, doing really well, from the evidence that we've currently have, there's no convincing evidence to say that there need to be an amino acid feed, and I would now normally start on an extensively hydrolyzed formula without any difficulties. So I can see we've managed to get through all of the questions, and I hope that you all have found this webinar very useful and have learned a lot. And again, I hope that you can digest some of the information. I do know that it's a lot of information that I've shared today, and the publications that I've shared are evidence heavy. So I've just picked certain areas that for me as a dietitian often can be quite controversial, but it might be that you have other nuggets of information that you find useful. So on that note, I'm going to finish this webinar, and thank you